Good afternoon, and I'm going to call to order the Assembly Committee on Health and Human Services. Madam Secretary, please call the roll.
Assemblywoman Benitez Thompson.
Here.
Assemblywoman Black.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Hafen.
Here.
Assemblywoman Krasner.
Here.
Assemblyman Matthews.
Here.
Assemblyman Orentlicker.
Here.
Assemblywoman Peters.
Here.
Assemblywoman Summers Armstrong. Assemblywoman Thomas.
Here.
Assemblywoman Titus.
Here.
Chair Wynn.
Here. We do have a quorum. I've asked Ms. Komlossi to record Assemblywoman Summers Armstrong present when she arrives. I know that she is currently presenting in another committee right now. And with that, I'd welcome our audience to joining us on this virtual meeting. We have 3 bill hearings, so I'm just going to get right into it so we can get them going and get them heard. And now open the hearing on Assembly Bill 205, which makes various changes concerning the acquisition, possession, provision, or administration of auto-injectable I don't know how to say this, epinephrine and opioid antagonists by schools. And with that, I will turn it over to Assemblywoman Cohen to begin when you are ready.
Thank you, Chair Wynn and committee, and thank you for hearing AB 205. Presenting with me is Trey Delap from Group 6 Partners. Mr. Delap has worked in behavioral health, addiction, and recovery policy for years and specializes in advocating in the spaces where they converge. So I'm going to turn it over to start to Mr. Delap.
Good afternoon, Madam Chair. Just confirming you can hear me.
I can hear you. Go ahead when you're ready, Mr. Delap. Make sure you state your name for the record before you speak.
Thank you. Madam Chair, my name is Trey Delap. I'm the Director of Group 6 Partners, and I'm here today on behalf of everybody, but on behalf of myself regarding AB 205, and I've been working with Assemblywoman Cohen on this bill. My role is to sort of update on the state of affairs with regard to some statistics that are relevant to this population. And I'm going to make some references to a document that was sent to you, but I wanted to talk about what's happened in 2020. 2020 was the largest year of overdose deaths Nevada has seen so far. And so the preliminary data for 2020 show opioid-related overdose deaths increased by 27% over the prior year to the highest single year number of fatalities since 2010 for all age groups. 51% of these deaths are attributable to synthetic opioids like fentanyl. Fentanyl is 50 times more potent than heroin and 100 times more potent than morphine. Preliminary data 2020 shows the number of unintentional opioid overdose death in 2020 was twice as high as the previous peak of 4 deaths in 2015. Between 2010 and 2019, the average annual number of opioid overdose deaths among the age group 8 to 17 was 1.7. In 2020 alone, these 8 deaths represent a 371% increase over the average established over the past decade. Nevada's youth are at a higher risk of opioid overdose death rate because 18.5% of Nevada high school seniors reported using prescription painkillers that weren't prescribed to them in comparison to the same age group in neighboring states, including 9.6% in Utah, 14.8% in Arizona. Non-medical forms of these prescriptions are manufactured nefariously and often include a blend of various substances, including fentanyl. Seizures of these illicitly manufactured drugs have increased 117%, according to Nevada HIDA. The combination of increased supply of highly potent synthetic opioids, indistinguishably and deliberately manufactured to appear like other medications, and a higher rate of use accounts for an increased risk of opioid death. That risk has shown to be realized, as the data show when we break it down from 2010 to 2020. The dramatic rise in overdose death among 8 to 17-year-olds has lowered the median age of unintentional opioid overdose death from 49 years to 29 years in a single year. Harm reduction as a strategy. Substantial federal dollars have been granted to states to promote harm reduction strategies inclusive of the wide distribution of naloxone to laypersons. State-targeted response grants have been distributed to states to expand access to naloxone. Nevada has distributed over 16,000 doses of naloxone since February of 2018. There's hope for young people in recovery. For young people with addictive disorders, there is hope at Mission High School in Las Vegas. This comprehensive school is the first public high school for young people seeking recovery in the United States. 50% of the students there are credit deficient, 100% have used alcohol or drugs, 38% have had involvement with the justice system. And at Mission High School, students are surrounded by peer community and supportive adults, giving them their best chance at recovery from addiction occurring so early in their lives. This bill would expand access to naloxone to more people, therefore increasing the opportunity that a overdose may be reversed. The key here is that the synthetic opioids are so potent that the risk is so much greater. And that's why this bill is very important. And I will stop there and thank you, Madam Chair.
Thank you, Mr. Delap. So the federal government, in an effort to stop the health crisis that has been escalating, has been giving out the opioid antagonist to prevent overdose. And this is without qualification. In other words, the medication is safe and can be given without harm. In fact, and this is confirmed by the following organizations: the Nevada Osteopathic Medical Association, which provided an exhibit for today's hearing in the form of a letter, the National Association of School Nurses, and the Substance Abuse Mental Health Service Administration of the United States Department of Health and Human Services. According to the Nevada Osteopathic Medical Association, naloxone, or Narcan, is a safe and effective drug for the treatment of suspected opioid overdoses. In the event that the drug is administered to a person who is not experiencing a narcotic overdose, but other medical events, it will not cause harm. So to be clear, if someone's overdosing from opioids, they'll die without intervention, but often lives are lost while waiting for the ambulance to arrive. And naloxone administered while waiting for the ambulance saves lives. And at the same time, naloxone is safe and more benign than epinephrine. In fact, it's administered to, if it's administered to someone who is not overdosing, it just doesn't harm them. So yesterday I distributed to the committee members a typical naloxone kit from Partnership Carson City. With money from the federal government, the Nevada State Opioid Response reports they have distributed 13,185 kits, and there have been 932 reversals from the use of naloxone. So reversal being someone's ODing and they're given the naloxone, and it basically saves them. So that's 932 Nevadans who would have died if they had not received naloxone. And as I hope you saw in the kits, because I hope you took a look at them, there's gloves, there's some information on opioids, instructions, and a couple of naloxone sprays. And as you can tell from the kit, you don't have to have training to save someone's life. However, organizations such as Partnership Carson City provide free monthly training, and the training takes from 30 minutes to an hour, depending on the length of time for questions. And in that training, the administration of naloxone takes up about 10 minutes of the training. The training also stresses calling for medical help. And I just want to make sure we're clear that even though I'm mentioning a Carson City organization, every county has an organization that will provide free to the public these kits and training upon request. So what we have here is there's a problem in that the rate of our students who are overdosing on opioids or using opioids and overdosing is rising. There's a way to solve it, which is using the naloxone or the opioid antagonist. And that way to solve it doesn't cause harm. If you accidentally give the naloxone to someone who isn't overdosing, it doesn't harm them. So there's something we can do about it. We can prevent the skyrocketing. The 8 unintentional overdoses that we've seen, that's a 300% rise in numbers. So we definitely want to address this issue. And so with this bill, it's a way to address this issue. So let me go through the bill with you. We already have laws that authorize specific medical professionals to prescribe and dispense opioid antagonists to anyone at risk for an overdose or to another person who might assist someone with an overdose. We also have law allowing for auto-injectable epinephrine in schools for treatment of anaphylaxis. And so what this bill does is simply allows for the opioid antagonists to be in our schools. So if we start with Section 1, that allows a healthcare professional authorized to prescribe an opioid antagonist to issue to a public or private school an order for opioid antagonists for treatment of opioid-related drug overdose and provide information. That section also provides information that's required in the order to the professional who's providing the antagonist. The section also includes that the healthcare professional is not liable for an error or omission related to that order, which is not gross negligence or reckless, willful, or wanton conduct. Section 2 authorizes a school nurse or other designated employee of a public or private school who has received training in the storage and administration of opioid antagonists to administer it to anyone on the premises of the school who is reasonably believed to be experiencing an opioid-related drug overdose. And so as you can see in that section, it's just adding the opioid antagonist language to the auto-injectable epinephrine language for having those in schools. Section 3 is conforming language in the maintenance and administration of auto-injectable epinephrine statutes. Section 4 establishes requirements relating to the storage, handling, and transportation of opioid antagonists in public schools and requires each school district and charter school to report to the Division of Public and Behavioral Health of the Department of Health and Human Services the number of doses of opioid antagonists administered at each public school during each school year. And this language is duplicative of the auto-injectable epinephrine language. Sections 5 and 8 require the Board of Trustees of each school district and the governing bodies of each charter school or private school that obtain the order for an opioid antagonist to establish whereby emergency assistance is sought each time a person experiences an opioid-related drug overdose on the premises of the school, and the parent or guardian of a pupil to whom an opioid antagonist is administered is notified as soon as practicable. So I could say epinephrine, can't say practicable. Now I can't say either. Anyway, moving on. Sections 5 through 8 of the bill require training in the storage and administration of opioid antagonists for the designated employees of the public or private school that obtains an order for opioid antagonists. Again, schools don't have to do this, but if they do this, there's just some guidelines that they have to follow, which sections 5 sub 2 and 8 sub 2 are clear that the schools may obtain the opioid antagonists. This isn't a requirement. It's a may, not a must. Sections 5 and 8 additionally exempt a school district, employee of a school, and certain other persons affiliated with the school from liability for certain damages related to the acquisition, possession, provision, or administration of auto-injectable epinephrine or an opioid antagonist, not amounting to gross negligence or reckless, willful, or wanton conduct. I'm working with a stakeholder on this. You'll probably hear from them. We want to just clarify what these protections are, and that the protections apply only in an emergency situation. So we are still working on that, but we're very close. We're in agreement. It's just getting the language. Section 9 requires a registered pharmacist to transfer an order for an opioid antagonist to another registered pharmacist at the request of the public or private school for which the order was issued. And that same section exempts pharmacists who dispense an opioid antagonist pursuant to the order from liability for certain damages related to the acquisition, possession, provision, or administration of an opioid antagonist not amounting to gross negligence or reckless, willful, or wanton conduct. And again, this is duplicative of the auto-injectable epinephrine language. And then section 10 is just effective dates. And with that, I think we are ready for questions, Madam Chair.
Wonderful, thank you. We have quite a few questions. Just right now, I have Assemblywoman Titus, Hathan, Assemblywoman Peters, and Gorlow in the queue. So I will start with Assemblywoman Titus.
Thank you, and thank you, Assemblywoman Cohen, for bringing back my bill. This was a bill that I presented in 2019, and I actually have to give full credit to Assemblyman Hambrick, who initially presented the bill, and Trey, you and I worked hard on this bill, and we got it all across through the finish line through both houses, and then it sat on a desk and died. So I am glad that you have brought this back. So I appreciate that, but I definitely wanted to give credit to Assemblyman Hambrick. This is one of his priority legislation that we couldn't get quite past the finish line. And so I appreciate you bringing it forward this session. As Trey pointed out, the pandemic has again shown us we were getting ahead of the opioid epidemic and the overdose deaths until this pandemic showed us where we were really lacking in it, and this surge is real. And so hopefully the members of this committee will support this, and it was pretty well vetted. I do have a question, however. I pulled up the old bill, and it's very similar. One of the previous concerns that were brought up with multiple testimonies, Trey, was the availability of Narcan. As an ER, I've worked the ERs, I've given way too many doses that I would have liked to do of Narcan, and there was some concern about its availability. I see now that this nasal spray, so as Assemblyman Cohen brought up, this is a nasal spray. So unlike the epi where there is a syringe involved, the auto inject, this is really a nasal spray. So really, as she pointed out, zero risk. So that was one of the other concerns in previous testimony is, how do you know for sure if you use it? Well, we testified that there was really no harm to give it. If you have an unconscious person, you can give them glucose in case they're diabetic, or you give them Narcan and see if they wake up or not. But there was always worried about the shot and the availability. So has the supply increased now that we could adequately supply everybody with Narcan? That's my first question. Then I have a follow-up, if I might, Madam Chair.
Madam Chair, if I can just address something, Leslie Cohen, Assembly District 29, before Mr. Delap answers that.
Go ahead.
I kind of want to be clear about the history of what happened last session. And certainly this is Assemblyman Hambrick's bill. And I promised him I would bring it back. It didn't sit on a desk and die. It basically was really getting watered down to the point of where it just didn't seem like it would have any effectiveness. So that's why I said to him, if you agree, I'll bring it back, because we wanted it to be effective and have something to it. So that's basically where it is and why I brought it back. But with that, I'll turn it over to Mr. Delap if he wants to answer that question.
Madam Chair, through you to Assemblywoman Titus. Thank you.
Mr. Delap, feel free to go directly to the member asking the question.
Thank you, Madam Chair. I think your question specifically was about the available supply of the nasal delivered of naloxone. That's something I would have to check. But this preparation of it, as you noted, there's no needles. This is the nasal administration spray. This is what's given to the lay public. I would envision that this is the most appropriate formulation. Well, the formulation, it's the delivery system that's the key detail. But this nasal spray does eliminate the needle fear and the worry of that. And there's a number of other things there. As far as the overall supply, naloxone's been around and proved safe since 1971. And again, thousands of doses have been distributed to the public. So if the question was, would we have enough to put some in every single school? I am supremely confident we could.
Follow-up question on that, Madam Chair? Has there been...
Great, too.
Thank you. When we heard this in the past, there was a lot of volunteers and some funds because this comes with a cost. And so the funding for this, lots of grants for the schools. Is that funding, have you seen it still available, either Assemblywoman Cohen, so that agencies, schools who wanted to get this perhaps could have some assistance? And then is there any agreement on the shelf life and turning in unused packets? Do we know any of that?
So Leslie Cohen, Assembly District 29. As far as cost, I think there's a couple of things we have to keep in mind. Number one, this is a policy committee. But number two, this, again, the language is not obligatory for the schools. It's a may. There are some federal funds, as far as I'm aware, but I think that's not really the point of the bill. We want to get something in place. And if the school decides they want to do this, they'll get the materials, they'll get the sprays. So that's where I think we need to focus. And then Mr. Delap, if you have anything to add to that.
Madam Chair, thank you. To Assemblywoman Titus, the naloxone that is distributed to the community is paid for by the federal government. And I find that to be a very compelling note for two reasons. One, federal grant dollars are being used to buy a medication to give to the lay public for the administration to people who may need it. That's a key detail. So when all of the doses that we've mentioned have been dispensed to the community, the state, have all been paid for by a variety of grant sources from SAMHSA, the Federal Substance Abuse Mental Health Services Health Administration. It's a big acronym. But the opioid STR grant, State Targeted Response Grant, was a major chunk of money that came into the state for the distribution of it. There's a number of resources that have dashboards and data and things like that. So that seems, in an interesting scheme of things, covering the cost of the product, there's probably the easiest part to solve.
Great. Thank you. Thank you for the questions, Madam Chair.
And we also have our policy analyst on that might be able to clarify that this is not an unfunded mandate because of that may language. Ms. Kamlasi, would you be able to come on and kind of clarify that as well?
Thank you, Madam Chair. Megan Kamlasi with the Research Division for the record. It is enabling language, and so school districts or schools would choose to participate in the program. I think what was said before is accurate. There are lots of sources of federal funds for this type of, for these types of naloxone kits, and they're being distributed widely. So it may even work for a school or a school district to work with local nonprofits or local community organizations to obtain naloxone as well.
Thank you. And with this, I'm going to next go to Assemblyman Hayden for our next question.
Madam Chair, my question was regarding the fiscal notes that were attached and the conversation that we were just having with the feds are paying for it. I know this is enabling language. However, I'm still confused if we're putting enabling language in so the schools can obtain the federally paid antagonist. And maybe I'll find that out in Ways and Means.
Leslie Cohen, Assembly District 29. Well, to be clear, the fiscal note that's up is zero, has zeros across the board, and we're allowing the schools to obtain the naloxone, to have it in the school, to use it if they choose, to have someone at the school trained to use it, which again is a very short training session, and not extremely technical. And if the schools choose, it's not that we're saying they can go get the money from the feds. We're saying they can do this, and we're saying that the feds have been distributing and providing funds for the kids, but they're not correlated.
Madam Chair, if I may.
Go ahead with your follow-up.
Clarification of my question. It was not the fiscal note for the state. However, it was on the local governments. The Clark County School District is showing roughly $182,000 over the biennium. And a number of the other school districts are also showing fiscal impacts to this. And I understand that we're trying to get the feds, and I do think this is a good program, but I just didn't want to get it on the record that there are fiscal notes from the local municipality.
And Leslie Cohen, Assembly District 29. I'm sorry, I'm not seeing those. I'm only privy to what's on Nellis for the public. So I'm not seeing anything from the school district. So my apologies. However, and there they are. However, I would just remind you again, it's as Ms. Kamlasi said, it's enabling language. So they can choose to do this or not. They can choose to do it and pay for it. They can choose to do it and find other resources to pay for it. But they will choose whether or not to do it.
Okay, we will go to our next question to Assemblywoman Peters.
Thank you, Chair. And just to clarify, I'm looking at the fiscal note, and it looks like there is some confusion from the school districts as to the accessibility of these resources and the need for training. So I would encourage that maybe there be a letter sent to them just letting them know where they can find this. And my question has to kind of do with the accessibility piece. And thinking about 17-year-olds that I know, 16 and 17-year-olds, some of them are incredibly capable people. And with kind of the prevalence of the supply, what is there anything that inhibits a student from administering something like this at their school? And then my other question is, if it is available to the public, what is the importance of having the enabling of the healthcare professional language in here?
Thank you, Leslie Cohen, Assembly District 29. And just to your first point, thank you for that. And in case there are any of the districts that are watching and interested, there was just earlier in March, there was a grant announced by the federal government, and it's on the SAMHSA page with information about how to get a grant for the kits. Then, as to your question, I'm sorry, would you state those again?
So it's about availability. So students potentially having this, in a backpack because they are careful and thoughtful people. Can they administer that on school property? And then the importance of having it spelled out in here, the enabling language for the healthcare professional to prescribe this at the school. What's the purpose of that?
Leslie Cohen, Assembly District 29. As far as a student, from what I've learned about this, they probably could do it, but this bill doesn't allow for it. That would have to be done by a different vehicle. The bill is for someone in the school to be trained an employee of the school to be trained to do it. As far as the, I don't know, maybe we can ask legal about Ms. O'Krentz about why the language is in there. The bill very much follows the epinephrine language, and that was existing epinephrine language about the prescriber. So I think the drafters thought it was necessary. And I think also because it is going to a school, maybe that's part of it, that we did need to specifically say that it is okay for the prescribers to prescribe it.
Charlie O'Krent, for the record, that's precisely it. I think that as this bill was originally drafted last session, it tracked the epinephrine statutes and so required the training that was required for epinephrine. It's certainly not a requirement that the bill maintain that same training requirement as it moves along through this legislative process, but that's why it was drafted that way.
Okay, thank you. That makes sense. I was just curious about the availability of Narcan. I have a box of it at my house that I was intending to take to an event this summer. So I know it's available and out there. I just wanted some clarification on the enabling. And then also, I think it's important to understand whether students can administer this if they have it available on school grounds, or whether there's liability associated with that. But it sounds like that's a separate issue than what we're talking about today. So I can clarify later. Thank you.
Thank you. And with that, we will go next to our next question from Assemblywoman Gorlow.
Thank you, Chair Wynn. And my question actually was already answered. However, talking through this, could somebody walk me through on what would it look like if somebody was overdosing? Just so that, if I'm at the grocery store or mall or in a park and someone falls over, I'm not so sure that this would have been my first thought to grab a Narcan and administer it. So what might some of the symptoms be for someone who is overdosing?
Leslie Cohen, Assembly District 29, and that is part of the required training. However, Mr. Delap, do you want to you had told me a story about a situation where someone was ODing and it took a while to figure that out and get the Narcan provided for that person? You know what I'm referring to?
Yes, Assemblywoman Cohen, Trey Delap for the record. Thank you for the question, Assemblywoman Gorlow. This would look like a variety of things. So the training would basically say, if you encounter someone who's unresponsive, not conscious, they may be in and out, they may not be able to talk, they're difficult to rouse, the protocol would be to call 911 or activate EMS or whatever. And then if you have the nasal administered Narcan, you would open it, and then the instructions on how to use it are in there. And then you would administer it. One caveat, and this came up the last session as well, is that Narcan is very effective only if someone has opioids on board, period. So it's like it's been described as a Lazarus drug. It does one thing: it blocks the effect of the opioid, so the person will immediately reverse. There are a number of cases, and one case that got some media was a highway trooper was in the middle of nowhere, and a person who was riding a bus was overdosing and unresponsive, and the bus driver pulled over, and the first responder was a highway trooper in the middle of nowhere. He had just gotten his training on Narcan. So his body cam footage actually shows the entire encounter, where he was attempting to talk to the person was unresponsive and was unable, they were doing the sternal rub, he was unable to rouse, and he actually kind of took him off the bus, and then there was some assistance. They were actually doing some CPR and rescue breathing. Then he remembered his Narcan, and then he administered it and in the meantime, he had called for a medevac helicopter. So a helicopter was coming. Then he remembered the Narcan and he administered it, and the patient woke up. So this is critically important, especially to communities where they're not 5 minutes away, where in Las Vegas, you might call an ambulance and 2 ambulances are going to show up within 5 minutes. But in other parts of the world, that may not happen. The major piece of legislation that had passed in 2015, the Good Samaritan Drug Overdose Act, which created NRS 453C, its intent was to protect individuals who would administer this to others, because the thing in the balance is the life of the person, and the intent of that bill is to relieve any hesitancy in that. But again, Assemblywoman Titus mentioned it. Sometimes in the clinical setting, this is used as a assessment tool, that if they administer the Narcan and there's no change in the patient's condition, that it's something else. But if it does change their condition, it shows that opioids were on board. So it would really look like someone who's unresponsive, maybe breathing, maybe not. The critical detail with this, and that's why the spike has been so bad. The synthetic opioid with fentanyl is so tiny, and when we look at the data from 2020, there was 1 death of a 14-year-old or younger. So these all 8 of the deaths that we talk about in 2020 were unintentional overdoses. That means someone was taking something and it overwhelmed their system. And that's the key detail. There's another example that was brought up where there have been some efforts. There's a program called OD Maps, and it's a computer program that basically tracks the use of naloxone by EMS. And what can happen is, if there's a number of reports in a specific area, then that triggers an alert. And now you know that there's a batch of this synthetic fentanyl-laced stuff in a particular area, and overdoses are going to start happening. So from a surveillance perspective, that's critical information. So the administration of Narcan is an indicator that opioid overdoses are occurring. And that indicator then prompts a stronger public response. And I apologize, that was a lot more than you asked, which was what does a single person look like? But that's the perspective.
Thank you. It was very useful information, so I appreciate you providing it.
At this time, I'm going to do one last call to see if we have any questions before I go to testimony in support, opposition, and neutral of Assembly Bill 205. Seeing none, broadcast services, can we please go to the callers, to the line about callers in support of Assembly Bill 205? I would remind callers to please clearly state and spell your name for the record and limit your comments to 2 minutes. And with that, we can begin.
To testify in support of Assembly Bill 205, please press *9 now to take your place in the queue. The caller with the last 3 digits, 655, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hi, this is Joseph Heck, HECK, representing Red Rock Government Relations on behalf of the Nevada Osteopathic Medical Association. Thank you, Chair Wynn and members of the committee. On behalf of the Nevada Osteopathic Medical Association, I voice our strong support for AB 205. We have provided a more complete statement for the record that is available on Nellis. While all attention has been fixated on the COVID pandemic, we cannot lose sight of other public health crises, to include the opioid epidemic that is plaguing our nation and state, and in some ways, the isolation and depression associated with COVID mitigation measures. That is why we applaud Assemblywoman Cohen's efforts to make naloxone, trade name Narcan, readily accessible in schools across Nevada. This safe antidote has proved effective in saving lives when administered by laypersons, and taking the same approach as the legislature used when making epinephrine auto-injectors available in schools is a logical and much-needed next step in combating opioid overdoses. We urge its swift passage. Thank you.
Thank you. We can go to our next caller in support.
The caller with the last 3 digits, 318, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Nguyen and members of the committee. This is Kendra Bertschy, Kendra Bertschy, and I'm with the Washoe County Public Defender's Office. On behalf of my office, as well as the Clark County Public Defender's Office, we want to thank Assemblywoman Cohen, as well as Mr. Delap, for bringing forward this important bill. We do hope and believe that this will save lives, especially the lives of our children. So we appreciate this effort. Thank you so much.
Thank you, Ms. Birchie. If we can go to our next caller in support.
If you have recently joined the call and would like to testify in support of Assembly Bill 205, please press star 9 now to take your place in the queue. Chair, we have no more callers in support at this time.
Thank you, Broadcast Services. If we can go next to our callers in opposition to Assembly Bill 205.
To testify in opposition to Assembly Bill 205, please press star 9 now to take your place in the queue. Chair, we have no callers in opposition at this time.
I believe we probably have a few callers in neutral. So if we can begin testimony in neutral at this time.
To testify in neutral to Assembly Bill 205, please press star 9 now to take your place in the queue. The caller with the last 3 digits, 756, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Jamie Ross, for the record, Jamieross. Good afternoon, Chair and committee members. I work in substance misuse prevention. We do have free Narcan and or naloxone trainings at our agency. With the increase of illicitly manufactured fentanyl in our drug supply in Nevada, our concern is the increase in fatal overdoses of children under 18 that occurred in 2020. Most of the fentanyl seen in Nevada is in fake pressed pills that cannot be differentiated from pharmacy manufactured pills. Youth who may not use heroin but perceive a pill of oxycodone to be safer than heroin would not be able to tell that this pill has fentanyl in it. The goal is to decrease overdoses and increase access to naloxone is a safe and effective way to do that. There is also currently a grant open through SAMHSA's First Responders Comprehensive Addiction and Recovery Act grants for funding for additional naloxone. Thank you.
Thank you. If we can go to our next caller in neutral.
Caller with the last 3 digits, 411, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you. This is Lindsay Anderson, LINDSAYANDERSON, on behalf of the Washoe County School District. Thank you, Chair and Committee. We're testifying in neutral today because of the enabling nature of this legislation and wanted to provide some context for the committee's consideration. Currently, our school police officers carry these kids through a grant at the Attorney General's office. We have a school police officer at every high school campus and shared between middle and elementary schools. We have less than 40 school nurses and more than 100 school campuses. Our clinical aides at each school do not have medical training. Asking them to decide between administering Narcan, epinephrine, and AED or other tools at their disposal to an unresponsive individual is a great responsibility. Lastly, we've not had a documented opioid overdose case on school campus in the recent past. I know this is a policy committee, but at least last session, the bill did not go to Ways and Means. I would hope that this session we may get an opportunity to discuss potential fiscal impacts in Ways and Means if necessary. Thank you, Madam Chair.
The caller with the last 3 digits, 080, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Madam Chair, members of the committee, Brad Keating, B-R-A-D, Keating, K-E-A-T-I-N-G, calling on behalf of the Clark County School District, calling in a neutral capacity on this bill since this is a policy committee. Just wanted to pass along a few important facts for the committee to know. AB 205 is proposing to have schools acquire, maintain proper and secure storage and provide training to licensed and unlicensed employees to recognize the signs and symptoms of opioid overdose and then to accurately administer an opioid antagonist while monitoring the student's response. Unlicensed assistive personnel at schools are often reluctant to be trained in administering injections particularly during a medical emergency when there are varying circumstances, to consider and careful ongoing monitoring of the student needs to take place. Also, the current basic life support guidelines recommend an automated external defibrillator, AED, to be available when administering an opioid antagonist. AEDs are only in high schools and administrative buildings in the Clark County School District, and therefore they would be the only sites equipped to manage an opioid overdose. Administration of those opioid antagonists would not be safe to administer in elementary and middle schools without the proper emergency equipment available, including AEDs. So again, this is a policy decision by the legislature. CCSD is testifying in neutral, and just wanted to provide you with those facts as you make a decision on this bill. Thanks so much.
Thank you. We can go to our next caller in neutral.
With the caller with the last three digits, 927, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, and thank you, Committee Chairwoman Nguyen and committee members. My name is Hava Ahmed, Hawahahmad, and I'm here representing the Clark County Education Association. The Clark County Education Association is the official bargaining partner for the Clark County School District, representing more than 18,000 licensed professionals, including school nurses, counselors, psychologists, and social workers. CCEA is testifying in neutral on AB 205. We appreciate the intent of the bill, but we do have questions on the policies for administration, notice that may potentially be given to parents, and we are slightly concerned about the implementation date being so soon with our current retention issues for teachers and licensed professionals. This isn't to say that we are not supportive of the intent of the bill. It is completely necessary, and we do believe that it will positively impact our students, especially our students struggling with opioid addictions. We just ask that the members that are on this committee that are also on the Committee on Ways and Means consider payment from the opioid for the opioid antagonist from the AG's opioid settlement funds, or a request that the Office of Grant Procurement Equivalent pay special attention to those SAMHSA funds. We look forward to working with the sponsor to ensure implementation of this bill is impactful, prevents all unnecessary deaths caused by opioid overdoses. And we're also looking forward to ensuring that this does not take money away from our classrooms. We are very thankful to the sponsor for stimulating discussion on this topic and bringing this bill forward. Thank you.
Thank you. And I will remind our people testifying in support, opposition, and neutral that this is a policy committee. So if you have concerns with some of these other issues, I suggest you bring them up with the bill sponsor or in our money committees. And with that, do we have any other callers in neutral?
Chair, there are no more callers in neutral at this time.
Okay, at this time, I will turn this back over to Assemblywoman Cohen for any closing remarks.
Thank you, Chair. Leslie Cohen, Assembly District 29. Mr. Delap, would you like to make any closing statements?
Thank you again, Madam Chair and Assemblywoman Cohen, and for the opportunity to talk about this. And for as long as we've had awareness that opioid overdose is a public health issue, we have been working on a number of fronts. And this is a piece of a much wider public health effort that involves how prescriptions are written, how much the prescription monitoring program is used. This, when we use the example of the layperson administering the naloxone, that's the expectation. And it's the intent of the Good Samaritan Drug Overdose Act to protect people, to encourage that kind of activity. There are a number of schools, and the National Association for School Nurses offers a number of resources in designing proper school policy. One that I found was with the Albuquerque Public Schools that had a policy, and they cited their Good Samaritan law as the rationale for that. So with regard to the implementation and how it might mesh with other policies, this one is interesting and nuanced in that we are educating the lay public with no medical training and no obligation to administer this drug. If they do it and the person doesn't need it, there is no consequence. Again, I don't know of any other medication or substance that has been publicly funded for mass distribution. One thing about the expiration date, for example, is that the FDA has extended the expiration for 3 years. So now they are good for 3 years instead of 1, and that was a change. So where it might be deployed in a school, I think there's a number of resources that can work with that, because there are school districts and states that have done this and done so successfully. The policy brief that was done by NICRIP, the Nevada Institute for Child Research and Policy, showed that a survey of school nurses showed that only 5.2% of school nurses ever administered naloxone. Well, if that 5% did, that means that's one less lost life of a student. And if we have the opportunity to do that, that's very valuable. Also, the education about opioid use and especially the extreme prevalence of the synthetic opioids is very compelling to some sort of action. So this is a dynamic process. There are a lot of community partners involved in this. We've done a lot of work. The legislature's done a lot of work. There's a lot of resources, and stitching that together is something that we can certainly do. I would be willing to have a conversation or work out the details as far as what the expectations are with this particular intervention. But again, this is so important, and just want to emphasize the final detail here is the tremendous spike. 8 in Clark County between 8 and 17 in 1 year. The peak was 4. So it's a huge spike. Also, 27% statewide of overdoses, unintentional, of the synthetic opioid. So we have a greater risk with these substances. So I really do think that we should do as much as we possibly can and what we can to overcome whatever barriers. I know that the auto-injector bill had some barriers and took some time. We don't have a lot of time when we see such a profound impact in a single year. Again, thank you for considering this legislation.
And, prior to going to Assemblywoman Cohen, I'm so sorry, I just didn't see it. Assemblywoman Venus Thompson, I think she had a question. I don't know if the people can answer it, but I will turn it over to her to see whether or not we can. And if we can get them back on the line to answer it, that would be great.
Yeah, and typically in a normal hearing, we're able to ask questions of people who testify. I know it's been a little bit different this session, and we really haven't been in the practice of asking questions of people who are testifying via the phone, but it's probably that point of the session where we can do so. So I appreciate that, Chairwoman, but I wanted to understand a little bit better some of the neutral comments by the school districts related to cost. I was trying to identify where in the bill they were kind of originating concerns about the cost. And so, and then someone had a concern about the implementation date. So I guess I'm not, and then I heard requests that this go to the Committee on Ways and Means, which I think is understood to not be practical because we only send things to Ways and Means that are under the purview of the state budget. And this isn't, obviously their budgets are their budgets, but since their budgets are their budgets, I guess I wanted to be able to hone in on the bill a little bit more where they thought specific costs were coming from. I know I'm looking at Washoe counties and I did the math and it looked like at $150 and then the amount they listed there, they were assuming 120 schools. So I think, getting the naloxone into every single school, but I don't see anything in the language that says that. And then on Clark County's one, it says indeterminate costs. So I just see different levels of response to the bill. And so it would be helpful for me to make sure that I'm reading it perhaps the same way they are.
We are trying to see if we can get them back on the line. I don't know if we're going to be able to. If they are listening, I know that our staff is trying to, but I believe that Assemblywoman Cohen could probably answer some of these questions because I know she has had conversations with them.
I think it's fine for the school districts to give us that. I mean, it's their argument to make, not the bill sponsors, but I think that would be helpful information to get for them to get to the committee is if they could just cite the specific section that gives them, that is causing the fiscal for those that have specific fiscals. If they could just help us understand the thinking behind that number, that would be helpful for me. And then that way we don't have to wait for them to come back on. If we get that information and then we can make that public, it would be helpful. I appreciate that, Chair.
Chair, so with your permission, I'll just wrap up Leslie Cohen Assembly District 29. I will say the mention of Ways and Means was my mistake. And I think they were just following along with what I had said. However, I just want to kind of address a few things that were said and that I have found to be an issue and kind of confusing from the parties that were neutral. So we've heard that, okay, well, there aren't nurses in every school, and that the aides don't have any medical training. Well, again, you don't need medical training to do this. You just need the training that is offered for free and is available. It's available online. So that shouldn't be an issue. Also, another statement that was made that I want to address is, we want the bill to say that you're going to get the funds from the Attorney General's opioid settlement funds. Well, my understanding is those aren't ours to play with. So they're the Attorney General's. So that's not really relevant. On top of that, another thing that I want to address and just stress as much as possible is this is enabling. It's enabling language. The districts don't have to do it if they don't want to. I hope that if we pass it, they will see their way clear for wanting to do this. And then one other thing is I do believe my understanding is, and I'm getting kind of a message from a doctor that there was a misrepresentation by the Clark County School District of the need for the AED with Narcan. There is no need for there to be an AED as part of the emergency response kit with Narcan. It's my understanding is it's two separate treatments and two different problems. And if a person is unconscious or unresponsive without a pulse, an AED is the first intervention that should be applied, but they don't necessarily have to be done together. So, and then I will also again reiterate with what Mr. Delap had mentioned about how when medical professionals don't know what's wrong with someone, they will give them the Narcan first because, again, it doesn't hurt them. So if they're in anaphylactic shock and you give the Narcan, it doesn't hurt them. But the reverse, if they're ODing and you give them the medication for the anaphylactic shock, that could harm them. So that's just something to keep in mind. I will certainly keep working with the school districts and try to get them to a place where they're wanting to do this. I will also provide more information about the AEDs to clarify that so that you're not listening to me, who is not a doctor. And with that, I appreciate your attention and questions, and thank you very much for the hearing.
Thank you. And actually, we have Lindsay Anderson back on the line, Broadcast Services. If we can go to her, that would be wonderful. The last digits, I think, are 411.
Chair, I do not have a call ending 411 right now, but if Lindsay Anderson can press *9 to raise her hand so that I can identify which call she is. And nobody has raised their hand, so I think she's disconnected.
Well, we tried. Again, I will reach out to the people that testified in neutral and have them try to address those things and get that information to the committee for your consideration. And with that, I will close the hearing on Assembly Bill 205. And at this time, I will open up the hearing on Assembly Bill 287. This bill provides for licensing and regulating of freestanding birthing centers. Welcome back, Assemblywoman Monroe Moreno, and please begin when you are ready.
Thank you. And good afternoon, Chair Wynn and the members of the Assembly Health and Human Services Committee. For the record, I am Assemblywoman Danielle Monroe Moreno, representing Assembly District 1. I'm here today to present for your consideration Assembly Bill 287, a measure providing for the licensing and regulating of freestanding birthing centers. Joining me here today in presenting this bill is Dr. Tara Rains, Ms. April Clyde, owner of Serenity Birth Centers in Las Vegas, and Ms. Genevieve Burkett, the Director of Nursing at Serenity Birth Centers. During the 80th legislative session, I presented, and this body passed with an overwhelming majority, AB 169, which established the Maternal Mortality Review Committee. It was important to pass that legislation because maternal mortality was and still is rising in the U.S., as it is declining in other countries. Sadly, as I said, we continue to be the only high-resource country whose rates are rising. Black women face significantly higher maternal mortality risk, currently at 44 deaths per 100,000 of live births, compared to their white counterparts and women of other races who are at 13 to 14 per every 100,000 births. But that was last session, and this is 2021. We're still battling maternal mortality. It's still an issue, but it's an issue while we're battling COVID-19. During the beginning of the COVID crisis, pregnant people were oftentimes forced to deliver in hospitals alone without their partners or without family members. And that was important because it was for the safety and protection of the hospital staff and other patients. And while I don't disagree with the decision that was made, I do understand the stress that it caused for families. I understand that because I had a number of constituents reach out to me and ask why we didn't have more options to have healthy babies where families could be involved. Thus, AB 287. Madam Chair, with your permission, I would like to share a short 3-minute video that can explain what a birthing center is much better than I can. And then after the video, turn it over to my co-presenters.
That would be fine. Have you
And I'll
set it
warn
up
you,
as broadcast?
this will be the first time I share a screen, so let's hope it works. Thank you, Madam Chair. Families in my community, and I'm sure in yours, are looking for healthy options, and I believe freestanding birth centers are one of those options. AB 287 simply defines in Nevada statute what a freestanding birthing center is. And with your permission, I return the remainder of this presentation over to my co-presenters. Thank you.
To remind your co-presenters to please state your name for the record before you speak, just so our committee secretary can keep track.
Excuse me. Thank you. This is Tara Rains for the record. With your permission, I'd like to share my screen and share a brief presentation.
Go right ahead.
Thank you. Apologies. Let's try this again. Thank you. So I'd like to talk a little bit about birth centers, the rise of birth centers in the United States, some outcomes associated with birth centers, projected cost savings related to birth centers, and ways in which they address disparities. And I'd like to close this presentation by stating my own personal connection to birth centers. So as was explained in that video that was previously shared, birth centers can be considered more of a maxi home than a mini hospital. They are a safe place for birthing people and their families to have babies, receive prenatal care, and then receive postpartum support. The major tenets of birth centers are prevention, sensitivity, safety, appropriate medical intervention, and cost effectiveness. Birth centers are centered in the midwifery model of care, which in its nature is relationally oriented. Birth centers respect and facilitate birthing persons' rights to make informed choices about their health care based on their values and their beliefs. And again, birth centers allow birthing people to define family as they see it fit, and also allow them to have family members present during their labor and delivery. The proliferation of birth centers is on the rise currently, as the Assemblywoman mentioned previously, particularly in the wake of COVID-19. We've seen an increased number of birth centers. Currently, there are 384 freestanding birth centers in the United States. There are none in Nevada. There's one birth center that is on the brink of opening. However, because there has been no definition, there have been some struggles, and my co-presenters are going to speak a little bit about that shortly. Currently, of all the U.S. birth centers make up a little less than 1%. This data has been updated by AABC, and it's now estimated that it's a little bit closer to 1%, which is a 200% increase in births in the last 10 years. We know that the outcomes associated with birth centers include lower rates of cesarean sections, cost savings, and increased client satisfaction. As previously mentioned, the U.S. currently ranks really poorly in relation to their peers in regards to maternal health outcomes, maternal mortality outcomes, and infant mortality outcomes. Most notably, the racial disparities in these outcomes is tremendous. As previously stated again, Black women are exponentially more likely to not only not survive childbirth, but to suffer severe disability following childbirth. We know, I want to go back to the slide for a second and just say, we know there's an abundance of literature that says that implicit bias in the medical community plays into this. I think there have been several high-profile stories, including Serena Williams, in which it's become clear that in the medical community, for whatever the reason, Black women's explanation of their pain is not believed by providers. Another reason why this relational approach, this midwifery approach to care is so important. Looking at some of the value we see in birth centers nationally, about 42% of births are covered by Medicaid in Nevada. that's looking more like 60 to 70% of births are covered by Medicaid. Birth centers are poised to save the state a tremendous amount of money, if nothing else, through the reduction of high intervention during birth. Again, looking at the cost savings, most recently, Washington, D.C. engaged in a Medicaid study to estimate about how much it would cost, how much it would save them to utilize birth centers for their low intervention Medicaid births. What they found was they saved around $1,163 per birth. Now, these numbers that I'm reporting for Nevada are not would not be entirely the case, and Nevada would have to do a cost study to see how much it would save the state. However, just based on my estimates, with 41,233 birth certificates issued in just Clark County in 2020, and if we estimated that 60% of those births from just Clark County were Medicaid funded, if every Medicaid funded birth in Clark County went to a birth center and we saved the same as Washington, D.C., it would save the state over $28 million. Now, realistically, that is, we know that it would be closer to 1% of births coming to birth centers. However, that would still save the state a few $100,000 just in Clark County alone. Additional implications for Medicaid, we know that if more pregnant beneficiaries used birth center services during the prenatal period for the duration of their care, they are more likely to experience better outcomes. Birth center care is a high value for Medicare beneficiaries. Currently, only a small fraction of Medicaid beneficiaries are able to obtain birth center care, and that is, again, due to the lack of birth centers. And the birth center model relies heavily on the Strong Start model of care. And what this is it's the use of the midwifery model in addition with group prenatal care, which allows birthing persons to build relationships during that prenatal period, find that peer support, find a group, and then offers wraparound services, family care, and home after to support things like nutrition and lactation in those first few days or first few weeks postpartum. Using the Strong Start approach, the American Association of Birth Centers versus national data found that in a number of maternal and infant health indicators, the Strong Start approach was much more successful and produced better outcomes. Specifically in relation to race, I think it's important to note that using the Strong Start model with African American birthing persons reduced the cesarean rate by more than half. Again, to close out, the birth center model of care benefits, it's time intensive, but it is relationship based. It includes referrals to needed resources, health education, emotional and mental health support. Midwives see fewer clients per day than OBs, and as such, they're able to really connect with their clients in a different way and support these positive outcomes. Incentivizing birth center use for prenatal care could permanently result in lots of savings to Medicaid. And again, those cost savings also come in the postpartum period because we know that you have better prepared parents, you have healthier breastfed and chest-fed babies, you have lower rates of cesareans and lower rates of interventions. And so briefly, I'd like to take just a few seconds to tell my story. I actually had 2 birth center deliveries in Colorado. What made the decision for me is I read the outcomes about the Black maternal health crisis, and I did not feel safe going to a hospital. I wasn't certain that that would be a place where my needs would be met and my voice would be heard. I went to an OB for my initial appointment when I found out I was pregnant. And having had a history of miscarriage, having had a previous loss, the OB said to me, okay, well, where you're sitting right now, it looks pretty good. You have like a 10 to 15% chance of miscarriage at this point. The next day I had an appointment with a midwife at the birth center. And she said to me after I told her my story, she said, well, knowing what we know, you're looking at like an 85 to 90% chance of having a healthy baby. And the difference in that perspective, the emphasis on the life that I was growing was what it took for me to realize that having a birth center birth is what would make me feel like an empowered, educated, knowledgeable person in during my delivery. I'd like to just give a few acknowledgements before I close. A lot of this information, these slides were taken from the American Association of Birth Centers. They've been fantastic. Monet Nicole Photography was kind enough to allow us to use photographs for this presentation. All of the photos in this presentation were taken during birth center births. And I'd like to thank the incredible community of birth workers in Nevada and across the country who work to empower their clients. And finally, my partner who allowed me to quit a tenured faculty position to pursue this work here in Nevada. Thank you for your time.
Thank you, Dr. Rains. Do we have any other presenters, Assemblywoman Monroe Moreno?
Yes, we do. We have Miss Genevieve Burkett and I believe Miss April Clyde.
Perfect. Thank you. Just remind you to say your name before you speak.
Hi, I'm April Clyde. I am started my maternal child career at Sunrise Hospital in 1998 as a labor and delivery nurse. So I have been doing maternal child here in Southern Nevada for a long time. The pictures that you saw, the birth center pictures of the building and inside, are actually my birth center that is hopefully weeks away from opening. I have started the process of first getting laws changed and now opening the center, but actively working to get the center open for the last 3 years. It has been such a challenging process. I honestly don't know that anybody following behind me without some law change is going to be able to see it happen. It has, most of that 3 years was working through city, fire, state. We're still working with the health department, kind of our final. So you see the birth center is ready to go. It's stocked with medical equipment. Instead of using the Commission for the Accreditation of Birth Centers, so a national organization that licenses and accredits birth centers, think hospital, the joint commission that accredits hospitals. They're the experts in that. They do that rather than looking toward, to state and city to do the licensing and the accrediting. What it is left for birth centers, like myself, is lots of people arguing and not understanding what we are. So the two closest templates that kind of fit in Nevada, what a birth center is an ambulatory surgery center and a nursing home. We are neither of these things. We don't have people that are anesthetized. Our moms are healthy, low-risk women. They're walking in labor. There are existing, patients. We don't have someone showing up at the door that isn't having prenatal care with us. They're walking out. Again, these are healthy women. We have an agreement with a collaborative physician, and in our case, UMC is 10 minutes away. So there's a plan, but because there isn't an understanding of this amongst health department officials and city officials, we are getting met with very things that are really delaying and that are delaying the process and not increasing patient safety. And so it's my hope that we see that no one else has to go through the journey that I have gone through, because there is incredible evidence to support that freestanding birth centers and the midwifery model of care increases maternal and child outcomes.
Thank you, Ms. Clyde. And if we can go to the last presenter, Assemblywoman Monroe Moreno. I think it's Ms. Burkett.
Hi, yes, Genevieve Burkett. I work with April Clyde.
Oh, Ms. Burkett, is there any way we can get you to speak a little bit louder?
Yes. My name is Genevieve Burkett. I work with April Clyde. Tara and April really have covered the majority of.
You know what? I'm sorry to stop you again, Ms. Burkett. I think we're all struggling to hear you. Broadcast services, is there any way you can come on the line and maybe troubleshoot her to turn up her volume?
Hello, Ms. Burkett. This is Broadcast Services. If you can just toggle the little caret next to your mute button and try changing your audio options.
You know, Tara and April really have covered it. I don't have too much to add. If you can't hear me, can you hear me now?
No, maybe your volume, or if you have anything covering the microphone.
Is this better?
Yeah, much better. Thank you.
Okay. Thanks for your patience. My name is Genevieve Burkett. I work for April Clyde. I'm an RN. And just to add on a little bit to what Tara and April have spoken to, evidence-based birth.com provides incredible amount of research showing that the midwifery model of care provides the safest and best outcomes for low-risk women. The Commission for the Accreditation of Birth Centers, our soon-to-be accrediting body for Serenity Birth Center, goes over an incredible amount of thorough review of birth centers before they're allowed to be accredited. We are working on an immense amount of policies and procedures. We provide training and drills and safety to all of our staff who are registered nurses and certified nurse midwives who are required by the state of Nevada to be at each birth and attend each birth. And I'm just grateful to be a part of it, and was a beneficiary of April's services as well. So that's what I have to say today. Thank you.
Thank you, Ms. Burkett. And the sound was so much better. Thank you for your patience committee on trying to get the sound right. Assemblywoman Monroe Moreno, do you have anything further, or are you ready for questions?
We can go to questions, or I can walk through the bill or the amendment, whichever you choose, Madam Chair. You let me know.
I think we can go ahead and take some questions. I know that we have a couple other bills on deck here, so I want to make sure we get to this. And I know we have quite a few questions on here. And I trust our members reviewed that documentation prior to today's committee hearing. I know that they are all very, very diligent. So with that, I'm going to actually ask the first question. Thank you for bringing this bill. I know that when I was pregnant and I was looking at birthing centers in Clark County for the birth of my first child, I quickly realized there were none. I had similar friends of my age that were also looking and were able to go to birthing centers. And so I was, obviously disappointed when I learned that that was not an option for me in Clark County. So I appreciate your bringing some light to this. Can you kind of explain how you think that these changes in this bill would allow for birthing centers to become more prevalent, and we can avoid some of the regulatory confusion that Ms. Clyde has obviously had to go through?
Thank you, Madam Chair. This is Assemblywoman Danielle Monroe Moreno. And I think it was explained really good by Ms. Clyde. She's had to jump through hoops after hoops after hoops to adhere to provisions for a traditional medical center that she is not. And we did not have in our statutes a clear and defined definition of what a birthing center is. And I think by putting that definition within our NRS, it will make it not only easier for her, but for other people in our community who qualify and are accredited or want to be accredited to build birthing centers and give options so we can have healthy mamas and healthy babies, give them options. But I think by making this distinct definition, it will make that process much easier. So when you have your next baby, there'll be a birthing center for you.
No more babies here. No more babies here. If we can go next to Assemblyman Matthews.
Yes, thank you, Chairwoman. Thank you, Assemblywoman Monroe Moreno. Question for either you or one of your co-presenters, perhaps. Can you tell me how many other states have this licensing and regulation of birthing centers? And in the states that do, if there's any kind of statistical correlation between the licensure and health outcomes? Thank you.
Dr. Rains, would you like to take that one?
Yes, currently 40 states have active birth centers, and the findings have overwhelmingly been that outcomes for birth center births are better as far as prenatal care, prenatal satisfaction, labor and delivery satisfaction, and postpartum support.
Quick follow-up, if I may.
Go ahead, Assemblyman Matthews.
Thank you, Dr. Rains. When you say better as compared to what? To births in under other circumstances, or just better health outcomes in those states in general? If you wouldn't mind just clarifying that, please. Thank you.
This is Tara Rains. Yes, better in relation to their peers in hospital births. And so the studies that have been conducted, and I have a few of them available at the end of the presentation, the studies that I'm referencing. Many of those studies are just looking at outcomes, looking at birth center birth versus hospital birth, or birth center birth and group prenatal support versus hospital and individual more typical prenatal support.
Thank you. Thank you, Chairwoman.
Thank you. If we can go next to Assemblywoman Gorlow.
Thank you, Chairwoman. And first, I just want to comment that I'm super excited to see and hear you guys talk about centering pregnancy. So really, really excited about that. But going through the bill, I was hoping you could clarify a little bit for everyone the difference between a freestanding birthing center and an obstetric center, and then also how in section 12.2, how we came to that 30 miles within a hospital, how that was determined.
I can answer. Okay. Genevieve Burkett. So a freestanding birth center is a birth center that is not attached to a hospital. And the state of Nevada determined that they wanted to call a freestanding birth center an obstetric center in their, correct me if I'm wrong, April, in their last set, or when they were defining what a freestanding birth center was for their legislation.
It's been called an obstetric center for decades in the NRS, and it just never got changed. Mm-hmm. And that's really where it was, I think, before birth centers were as prevalent.
And I'm sorry, Ms. Clyde, can you say your name for the record before you speak, just so we have a clear?
Yep, I'm April Clyde, nurse practitioner. But yeah, the obstetric center, the phrase obstetric center is just a holdover from NRS. I think it's been in NRS for decades. And it just didn't get changed, and and it was before freestanding birth centers were as prevalent as they are now. So I don't think that there isn't a difference in that we're talking about the same thing. It's the problem is when you call it an obstetric center, I think that people are confused because a freestanding birth center is called out in functional guidelines and other regulatory. It's not called an obstetric center in other states or another regulatory wording.
And correct me if I'm wrong, because I kind of got the impression the obstetric center was mostly just for deliveries, but that the birthing center did the prenatal care, did the birth and postpartum care. So it encompassed more care than what just an obstetric center would cover.
Correct. That at a birthing center, that it is all of it. It's care through what we call the birthing year, from preconception through. We care for moms and babies for 2 months after delivery as well.
Thank you. And could you explain also how we came to that 30 miles of a hospital for the birthing center?
I am not sure. So there is some research that supports this, that being within, and some research says 30 minutes, some research says 60 minutes, that outcomes are better when there's that distance from the birth center to, and specifically to a tertiary care hospital. So a big hospital.
Thank you so much. Oops.
This is Tara Rains for the record. I'd like to expand on April's response to the distance question. So there is hot off the press, fresh research from late 2019 where they looked at distance for rural birthing people to hospitals. And what they found is for low intervention births where the birthing person knew in advance that they were going to be far away from a hospital, that there was no benefit to being closer to the hospital. So the key to that would be making sure that people are prepared to be farther from a hospital. And I know that is part of this legislation, but it would be phenomenal if it wasn't, simply because birth centers are poised to really support our rural communities and places where we're finding that there is obstetric care deserts in Nevada. And so having that anchor to a hospital could be limiting.
Thank you very much.
To speak to that, I've had a home birth practice I've worked in hospitals and out of the hospital, but I have many families that travel from hours away in Nevada to birth here because there's not a hospital where they live.
Thank you for that. And next going to go to one of our representatives who represents a rural district. If we could go to Assemblyman Hazen.
Thank you, Madam Chair, and thank you, Assemblywoman, for bringing this bill forward. One of my questions has to do with the current birthing center that's up north here. I know it's not a freestanding birthing center, which I believe is what this bill is addressing. It's just the freestanding, but I would just want to clarify on the record that there would not be additional licensing requirements for that current birthing center.
This is April Kite again, nurse practitioner. Are you referring to the Melinda Hoskins Birth Center in Minden, or that's another? Because I think that's the only one I'm familiar with.
It's my understanding that there's a birthing center associated with Renown up here, and I am from down south, so I'm not very familiar with it. But
Assemblyman Hafen,
we're not adding additional burdens onto the current facilities the current birthing facilities that are here.
This is Assemblywoman Danielle Monroe Moreno, Chair Wynn to Assemblyman Hafen. No,
feel free to go directly to the
Thank you so much for that. No, this legislation would only refer to freestanding birthing centers. It would not have an impact on those birthing centers that are associated with our hospitals or cause any other licensure that they would have to get.
Thank you for that clarification. Thank you, Madam Chair.
No problem. Next, if I can go to Assemblywoman Benitez Thompson.
Thanks so much. I appreciate that. And so I think that the first line, the thing that was most interesting to me, especially when we talk about licensing questions and like where people fall in licensure, is that they can fall, we can only regulate what happens if the state has put on to the law books about licensure. And then we say, okay, you're within the scope that the state can intervene. So I thought it was particularly interesting to hear the testimony that you're kind of living between two different licensing types, an ambulatory surgical center, or I believe you said a nursing home, but we're neither one of those things. And so it is hard because, I guess this would be more than a comment than a question, like what what we've experienced before is, and I don't think that this is anything that Miss Clyde would ever do, so please don't take these as representations towards you, but you could see someone who might have less honorable intentions or less, I'll say transparent intentions, right? Where, and we've seen this happen in other types of licensing groups, where people start practicing, and because we don't have a clear law about what they can and can't do, we can't go in and regulate them, right? We had this problem for years with group homes, and then we were trying to define in group homes and define in group homes because our state regulators or ombudsmen would walk in and go, you look like a group home. And they say, well, no, I'm not, because here's what you say a group home is, and I'm not licensed as that. And since I'm not licensed, you can't touch me, right? And so then we'd have to, we were constantly chasing through the 11 session and the 13 session and through the 17 session, trying to get these people onto the map. And so one thing that I've always appreciated when it comes to saying, here's a clear path for licensure, is everything that's happening in your community, and everyone who's willing to hang out a shingle and be transparent is known. And we have a better idea of what's happening versus just, if we only have a space where people exist ambiguously without state oversight, then they will exist there. So I guess that's what I always appreciate when we talk about trends in a community, is if we think it's worthwhile and we think it ought to be done safely, then we ought to have a serious conversation about regulations and licensure and how we ensure that it is done safely. That's just my comment.
Assemblywoman Benitez Thompson, this is Assemblywoman Danielle Monroe. I truly appreciate you saying that, and I truly appreciate the staff at Serenity Birth Center. They could have started this business 3 years ago and just opened their doors because they were in between. But it's very important to them and other midwives that I have been working with and the nurse midwives on another piece of legislation to make sure that our policies as a state, the statutes in our Nevada revised statutes, are clear and concise, and they will take as long, and it's been a long time, unfortunately, to make sure that they're following those guidelines and making sure that within this legislation that there's enforcement, and that you'll see that in sections 17, 18, 20, and 25 to make sure that they're adhering to what we will set forth in this policy as we move forward. So thank you for your comments, and thank you to them for following the guidelines that they did have in that in-between space.
Thank you. Next, I'm going to go to Assemblywoman Titus. I know she has quite a few questions, so I will ask her to try to be as concise as possible with asking them.
Thank you, Madam Chair. I appreciate the opportunity to ask a question, and I appreciated all the discussion that we've had so far and all the excellent questions that were asked. Just to be clear, I did my OB training as a second-year resident at LA County General. As an MD, I spent 2 months down there delivering babies every third night, where we literally would deliver 50 babies, and it was everything wrong that this bill tries to solve. No prenatal care. We caught them as they came in the door. It was an amazingly intense experience, and I was pregnant at the time for myself. When I chose to have my babies, I had them at St. Mary's, where they have wonderful birthing rooms, where you do have someone you can have with you. The baby never leaves the room, and it was a wonderful experience for me, not unlike, unfortunately, some of the testimony we heard today. Having said all that, however, I have some questions regarding this bill in particular. First off, someone testified that that in order to partake in this, you already had to have prenatal care, or you couldn't go to one of these birthing centers. Is that correct?
This is Tara Raines for the record. No, I'd like to clarify. In my own personal story, I went to an OB as I was trying to decide if I wanted to pursue a typical route versus a birth center. No, the birth centers provide OB care, and in many cases, birth centers provide fertility support and well-person care for folks who are trying to conceive.
Okay, and so a follow-up a little bit, if I might, Madam Chairwoman. These birthing centers, are they all for-profit centers?
This is Tara Raines again. No, it's a mixture. There are some who are for-profit. Many of them operate as nonprofits. So it just depends on the model of the owner and operator.
So there are some nonprofits.
Absolutely.
And birthing centers then affect issues like people walk into the birthing center, they're going to have their baby? Is there any EMTALA violations, or what rules do you have to follow? Do you can you turn somebody away? Question.
These are good questions. It is not like a labor and delivery unit at a hospital that you can show up with to get to the note. You have to be, it's for healthy, low risk women. So you cannot, having no prenatal care risks you out for care at a birth center.
So so will you accept Medicaid payments, and do you accept cash payments, and will you accept somebody who has no means of payment?
Yes, and it is far less expensive when you're comparing vaginal birth to vaginal birth, the apples to apples, far less expensive to birth at a birthing center. And we accept Medicaid, and we do accept women with late care, so that are beginning care, prenatal care in their second trimester or even their third trimester. But you can't, like a hospital, show up and have had no prenatal care.
Well, having done OB out in rural Nevada, which is far away with no backup, I know that birthing can be a wonderful, wonderful experience. It was something that I felt as a family practice doctor. To be a complete family doctor, I needed to do OB. At the same time, and we would select our low-risk patients. At the same time, unfortunately, even in low-risk patients, there is at least the statistics that I've been looking at sitting here. About 20% of the ones that I just looked at will be transferred to a hospital. That's the current rate that I just see nationwide of these birthing centers. 20% will ultimately, even in the low-risk moms, be transferred to a hospital center for either some sort of assistance with delivery, some sort of medication recovery. How do you deal with that? How do you deal with the transfers? Do you have to have agreements with local hospitals for those potential we know will happen even in the best of circumstances? How will you deal with those pregnancies?
So of that, and I don't know where I think the number is 12% is and I think the 20% may be total transfers. So when we're talking beginning of prenatal care through.
Correct. That's the figure, 20% total transfers. Yes. So
most of those are happening through prenatal care, that someone gets gestational diabetes, someone has high blood pressure, someone, and they become not a candidate for, because what we're the experts in is we're the experts in normal, which is the vast majority of pregnant people in the United States, but that's what we're the experts in. We do have, so speaking for our practice, we have a collaborative agreement with the School of Medicine OBGYN department.
And that's what I need. So you have an agreement with another center, and will there be any requirement for the other? So I respect what you're trying to do. Will there be a requirement at all that there's an agreement with other facilities for the known complications or the safe handoff, those kind of things, so that the transition is living in the world and having it happen? It's important that you know that when it does happen, you have that handoff, the warm handoff. So do you have any kind of requirements for that?
This is Tara Rains. Currently, there is no requirement for that in the legislation, and I believe that is to reduce barriers. I think what other states have found is that some of the hospitals have not been as excited as we are to see birthing centers in their communities, despite the positive outcomes associated. Of course, AABC and all birth centers would be strongly encouraged to develop formal relationships with hospitals. But what I think folks have found is that what April said, the early risk out, right? So the folks who are encouraged to find other care long before delivery, and then building relationships with both emergency departments and local OBs have been incredibly helpful for birthing centers and transfers. I know in the birthing center where I delivered, they had a relationship with a local hospital, and I was encouraged to just go check out the hospital ahead of time in the event that I did have to transfer for one reason or another.
And that again is kind of where I'm going with this question, because again, it's that safe transfer and understanding that. And one of the arguments for this bill is the poor outcome, especially as you quoted in certain groups of women. And I'm just wondering if all these requirements are there, you're almost pre-selecting that these women won't qualify for this birthing center. So I'm just wanting to make sure this is really helping solve a problem that you're truly trying to solve.
So I would also add, this is Tara Rains again, I would also add that one of the key pieces of the birthing center is that prenatal education, that nutrition support, that mental health support. And we found that with those pieces, going back to that centering model, particularly with the group, but with these pieces in place, it reduces morbidity. And so if I am a super low income, very, very young birthing person, and I'm getting this nutrition support, I'm getting support around healthy choices, I may not develop that gestational diabetes that would risk me out. I may not develop some of these other morbidities that we would consider disqualifying factors for birth center supports. So I think the idea is to take a preventative approach.
Almost done, Madam Chair, if I might. Liability. So what type of liability coverage is mandated for these services?
So all of the providers that have to be there at every birth, the way the law is now is a nurse practitioner, nurse midwife at every birth, and an RN at every birth. The nurse practitioner and the practice is required to carry a 1 million, 3 million policy. This is the same as OBGYNs or any other, yeah.
Right, that was my limit, 1 million, 3 million to OB, and that was expensive, obviously. Final question, if I might, Madam Chair, sorry. In these birthing centers, since you're asking to be outside, and again, I like the concept, I like having somebody there, I did that. I mean, I stayed by their side, I did that. It was a wonderful experience to deliver a baby, but having had the experience of home deliveries, emergency deliveries, roadside deliveries, in my house deliveries, I can tell you I've run the gamut here, and there's many different avenues there. And it can be exciting, but it can be terrifying and just that quick too. So the thing about it, you have to require, if we're outside the other requirements for an obstetrical center or a hospital, are you going to be required to have resuscitative equipment there, emergency equipment, that post-hemorrhage, those kind of things? And will you be able to use a PIT? Will you be able to use anything if they don't stop other than massage of the uterus? What will you be required to have in your facility?
This is April Kite again. I love all of these questions. Who knew I was going to get a doctorate? So these are great questions. And so the Commission for the Accreditation of Birth Centers, Assemblywoman Titus, think JACO, think the Joint Commission for Hospitals. They require everything you just described that we have to have. So all of those, we have to have a crash cart, a resuscitative equipment for mom and baby. We have an AED machine, all of the anti-hemorrhagic medication that all has to be there. That's all a requirement for accreditation.
Very good. All right. Thank you for the bill. Thank you for the litany of questions that you allowed me, Madam Chair. And I appreciate it. Thank you.
I'm sure Ms. Clyde is enjoying being able, and Dr. Rains are enjoying being able to answer these questions as well. If we can go next to Assemblywoman Krasner.
Thank you very much, Chair Nguyen, for this opportunity to ask a question. And it goes off a little bit of Dr. Titus's question. So will these birthing centers have the equivalent of a NICU, neonatal ICU? Will they have the equivalent of those services for babies born in fetal distress?
It's an excellent question. We have the same ability as a level 3 NICU. So a well nursery. This is what most rural hospitals in Nevada have. Still, even some of the hospitals, more suburb hospitals in Southern Nevada have. So we can take care of well newborns. We do have resuscitation equipment, but we don't see preterm babies. You have to be at least 37 weeks to deliver at the birth center. Everybody that is, so the RNs, the nurse practitioners are all neonatal resuscitation trained. And so if there was a resuscitation, we also have protocols with the 3 fire departments that could be responding if there was a situation where a mom or baby needed to be transported to the hospital, that we have, will be, in fact, it's happening next week, where we're running drills with them for transport.
So, I know there's different levels of hospitals in regards to their immediate and urgent care that they can provide. And this sort of goes to Section 12, Sub 2, talking about the freestanding birthing center must be located 30 minutes from a hospital that offers obstetrics and emergency services. When I gave birth to my first son, I was super healthy, only ate nutritious foods, vitamins, very healthy, low risk pregnancy. And I was offered to, because I was a low risk pregnancy, give birth in a hospital. It was kind of in a rural area, but they didn't have the highest level of services for a child born in fetal distress. And they were 15 minutes from a hospital that did. And I just opted to go for the hospital that had the experts and the whole bells and whistles and doctors and nurses. Thank goodness, because even though I was a low risk pregnancy, my son was born in fetal distress and he would have died. My doctor told me in 15 miles from that hospital to the other one, he would have been dead. Who would have known? I was low risk, and this really concerns me. So if you could please address those concerns. Thank you.
So in a birth center, babies are getting monitored.
Ms. Clyde, can I have you state your name again?
April Clyde. I'm a nurse practitioner with Serenity Birth Center. So there has been a lot of research comparing what's called intermittent fetal monitoring. So this is what's done at a birthing center, where moms can be in any position, they can be in the water, and we're listening. And there's a protocol, a national protocol for this listening, and then compared to what's done in the hospital, continuous fetal monitoring. So people in the United States are more familiar with this, where there's a wire, there's a little belt on mom that's connected to a wire and a machine that's continuously monitoring the baby's heart rate. There has not been found a difference in mommy outcomes or baby outcomes with continuous monitoring and intermittent monitoring. There will be babies that need to be resuscitated, just like there's, you're in labor room 1 and they're planning for a normal, vaginal delivery, and, that there's distress and mom gets moved either to the operating room or that staff come in for resuscitation of baby. These same protocols are planned for, and that we have emergency services and emergency personnel there to resuscitate a baby if necessary. We also aren't waiting for emergencies to happen. If babies are not tolerating labor well, if we're hearing, decelerations in the heart rate, we're going to the hospital, and we have oxygen and emergency equipment to be taking baby to, mom and or baby to the hospital.
Thank you, Chair. No further questions.
Thank you, Ms. Grasner. I think we have one. Vice Chair Peters, did you have a question?
I don't really have any particular question. I just want to commend you all on your presentation and the bill and the amendment, which is fantastic and novel. Great job. This is really, really wonderfully written and well thought out. I also just want to say that having had 3 kids at home and doing all of the research on every one of those children and the variety of health that I had as a pregnant woman, which I've shared some of on here, probably too much information for most people. Where you choose to birth is really kind of an intuitive choice. And Assemblywoman Krasner, you used your intuition to decide where was the best place for you to birth. And really, I think that the idea of options is kind of directed at exactly that women, we should trust women and their bodies and their intuition and willingness to listen to themselves and take in information and understand what the risks are for them and their babies and give them the opportunity to make those choices themselves. This really is about like that right to be a parent. And I think I really commend this bill sponsor and the folks who are advocating for this and the people who are standing up these kinds of facilities, because you are enabling women and birthing people to do what's best for them and their families. So thank you.
Thank you. And with that, I think this is a good stopping point to go ahead to the lines to testimony in support, opposition, and neutral of this bill. Broadcast services, can we go to the lines to begin testimony in support of Assembly Bill 287? I would remind callers to please clearly state your name for the record before speaking, and please limit your testimony to 2 minutes. I know that 2 minutes goes by fast, and I would also encourage people to submit any written comments as well within 48 hours of today's hearing. And with that, let's begin.
To testify in support of Assembly Bill 287, please press star 9 now to take your place in the queue. Chair, there are no callers in support at this time.
Can we go to the line for any callers in opposition of Assembly Bill 287?
To testify in opposition of Assembly Bill 287, please press star 9 now to take your place in the queue. The caller with the last 3 digits, 122. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Nguyen, members of the committee. For the record, my name is Katie Ryan, K-A-T-I-E-R-Y-A-N, and I'm System Director of Nevada Government Relations for Dignity Health St. Rose Dominican. I'm calling in opposition today to AB 287, and I provided a letter on behalf of St. Rose and our Chief Medical Officer, Dr. Rob Buzzes, which describes our issues with the bill. We want mothers to be able to have their babies in a comfortable setting, but we also want to make sure that those settings are as safe as possible and close to a higher level of care if needed. Thank you.
Thank you. If we can go to our next caller in opposition on Assembly Bill 287.
There are no more callers in opposition at this time.
Do we have any callers in neutral on Assembly Bill 287?
To testify in neutral to Assembly Bill 287, please press star 9 now to take your place in the queue. Chair, there are no callers in neutral at this time.
And with that, I will turn this back over to Assemblywoman Monroe Moreno for any closing remarks. I don't know if your co-presenters have closing remarks.
Thank you, Chair Nguyen and committee for giving us the opportunity to present this bill. I think Assemblywoman Peters looked at my notes because she completely stole my closing remarks. There's absolutely nothing else that I can say. I see birthing center as another option for mamas. And women, we should trust women as what they want to do with their bodies and where they want to give birth to their babies. If it's at home, in the living room, in a pool, in a hospital, or in a birthing center. So I thank you so much for listening to this bill, and I urge your support. Thank you.
Thank you for that. And with that, I will close testimony and close the hearing on Assembly Bill 287. At this time, I will open the hearing on Assembly Bill 426, which makes various changes related to the protection of children. I think we have Buffy Joe Akuma and Chief Deputy District Attorney in Washoe County District Attorney's Office, as well as Gabriel Carr, Juvenile Master in the 6th Judicial District Court, who will be here to present our bills. So I will turn this over to them. Welcome to HHS, and begin when you are ready.
Thank you so much, and good afternoon, Madam Chair and Assembly Committee members. Thank you so much for the opportunity to meet with all of you today. I I am Gabrielle Carr, and I serve currently as the 6th Judicial District Court Juvenile Family and Court Family Master, and I also serve as chair for a subcommittee of the Community Improvement Program, which is part of the Nevada Supreme Court, that was created to create this bill. And I have as my presentation today two things. Just one, a brief introduction of the presenters that are with me today, and then a brief overview of what this committee was created for and why it even came into existence. So I appreciate that you've been listening to a lot today, and I will do it as briefly as I can. Even though just about my team and my presenters, as the chair, I've also been practicing family law and related cases, including child dependency, for about 25 years and now on the bench. So I've covered it from all aspects of dealing with representing the parents, the kid, representing the child welfare agencies, and now actually overseeing these cases. And also with me as a co-presenter today, I have Ms. Buffy Okuma. As mentioned, she is the Chief Deputy District Attorney for Washoe County, and also available with us today to answer questions is Chief Deputy District Attorney Jan Hanrahan from Clark County. So you have Washoe, Clark, and the rurals represented by our presenters today. And just to give you a brief overview of why and how we got here. So I mentioned the Community Improvement Program that's through the Nevada Supreme Court, and that program was created to allow all of the districts within the state to come together and work together as a team to improve outcomes for children in child welfare cases. And so this team of CIP stakeholders involves judges and masters, attorneys, social workers, guardian ad litems, administrators, Nevada Supreme Court staff, and that's managed and controlled by retired Nevada Supreme Court Justice Nancy Seda. So we have every year this meeting where we all come together called our CIC Summit, and all the teams come into one place and we talk about how to do things better. And I decided to stand up in front of the team and in September of 2019 and said, Justice Seda, why don't we create a committee of people to address all the issues that we're having with Chapter 432B? And she said, well, it sounds like you'd like to chair that committee. Okay, I guess I'm going to be chairing this committee. So I reached out to all of the stakeholders that attend these meetings throughout the districts and created a team. And I have shared that with your staff, but if with permission from Madam Chair, I'd like to share that participant list so that you can see who we have in this team.
No, that would be fine. Go ahead and share your document when you are ready.
Thank you. So this is just simply a list of all of the stakeholders that were contacted, including others, that joined this subcommittee along with me. And luckily I had Ms. Buffy Okuma join me as the co-chair of this committee. And we have been meeting for approximately a year, every month, sometimes every week, to come together and see what can we do to address all the issues we're having under Chapter 432B. I believe that you all may have a copy of this document, so I don't want to spend too much time on it. I just wanted you to see that we have representatives from the Nevada Supreme Court, the state of Nevada, all jurisdictions except for the 10th Judicial District, and including our director for the Court-Appointed Special Advocates, or CASA program here in Nevada. Now, this committee, in meeting every month, one of the things that we agreed to do was whatever changes we wanted to move forward in this bill had to be unanimously agreed to by all committee members. And if you know what it's like to work with very strong personalities and educated individuals, and all of us to be able to unanimously agree, we did. And our goal was twofold. One, clean up anything that needs to be updated and modified to fit the practical application in the community as we deal with these cases on a day-to-day basis. And two, address the fact that in 2011, there was a Ninth Circuit Court of Appeals opinion that said, now in these cases, before a child welfare agency can remove a child, you have to have a warrant from the court. Well, that warrant process is different for every jurisdiction. So part of our goal in this was to codify the need for a warrant and make it more uniform so that the districts could have a greater, more uniform application of that. So with that brief overview, I just wanted to let you know kind of where we're coming from and why we're here. And then I will, if I may, Madam Chair, turn it over to Ms. Buffy Okuma to explain more of an overview of our bill draft request today. Thank you.
No, that's fine. I just remind her to please state your name for the record before speaking.
Thank you. Buffy Okuma. I'm with the Washoe County District Attorney's Office, and I'm the Chief Deputy District Attorney for our Child Protection Services Unit, where we have a total of 8 attorneys who represent the Washoe County Human Services Agency, solely doing matters with regard to 432B all the way through termination of parental rights. So it's my pleasure to be here in front of you, Madam Chair, as well as the committee members. And I'm going to do just a very brief overview, a couple of additions to what Master Carr talked about. Within our committee, we identified as a group a number of areas that we wanted to address. Pursuant to our agreement for everybody to have consensus on what we were going to work on, and we had a pretty short time frame. We got started a little bit late. We decided on several topics, and then we ended up narrowing those down. There's a few kind of heavy lift topics that we weren't able to get consensus on to move forward. But the benefit of that was that we now have kind of a platform for how our committee can come together to propose legislation and legislative changes to the various chapters that we deal with every day. So what we ended up with was essentially 2 main topics that we moved forward on. One topic was the warrant process, and then the other topic was basically just cleanup of all of those things that we've all been kind of having to kind of overlook and fudge around in order to get the practice moving and to be able to get our cases going. So those were our 2 primary focuses. Master Carr mentioned the Court of Appeals opinion. The first Ninth Circuit opinion actually came out, one in 1999 and one in early 2000. So it was on the radar in Nevada for quite a while, and it ultimately resulted in Washoe County Human Services Agency being sued, and thus the opinion that Master Carr is referencing. During that time period between the early 2000s and when that lawsuit occurred, there was conversations all the time about the need for a warrant, and the response was always, but we don't have any process. There's all kinds of processes in place for criminal cases, but it hadn't been applied in the child welfare world until the early 2000s. So it was a struggle to get the process in place. And I will say that the implementation across the state of Nevada was extremely slow and disjointed. And we've talked for years about trying to get the warrant process codified in 432B so that we all, one, can not have to patch together a bunch of case law to figure out what is required, but 2, to try and be a little bit more consistent from jurisdiction to jurisdiction, but at the same time recognizing the differences. And I think we accomplished that with Section 1. So that's Section 1 of the bill. Section 2 of the bill, it was just a conforming change, so really nothing to mention there. With regard to Section 3 of the bill, again, nothing significant in that one. It just provided for some clarification. Section 4 of the bill, also a conforming change to recognize the warrant process. When we get to Section 5, we added this one word, but it's a really powerful word. We added the word that we would have jurisdiction in any county where a child is domiciled. I can't tell you how many cases we get. In Nevada, just for some edification, we have 3 separate child welfare agencies under 3 separate jurisdictional overlays. In Washoe County, it's handled by the Washoe County Human Services Agency with the District Attorney's Office representing them. In Clark County, the cases are handled by the Clark County Child Protective Services Division, again, with the Clark County District Attorney's Office representing them. And then in all the rurals, the cases are handled by the Division of Child and Family Services with the Attorney General's office as their legal counsel, though they don't participate in the actual hearings until it gets to a termination phase. So it's a little bit disjointed, but far better than it was back in the 90s. With that, when we have jurisdictional issues, and in the north, often between Carson City and Washoe County, and there's a few similar situations down in the south, oftentimes we will have a family that lives in Carson City, but the child is born in Washoe County, generally at Renown, because of the specialized services that Renown offers. Interesting that we came up just after the birthing center bill. But we have this situation multiple times a year where the child's born in Washoe, but the family parents have resided in Carson City. And our statute previously, as it currently stands, is pretty narrow. It says that a court has jurisdiction where a child resides or where a child is found. So when you have a newborn baby, they don't really reside in the hospital, but they're certainly found there, but they've never resided anywhere else. And so we have situations where Washoe County has had to take action on that case and go to court in Washoe County and then go through a big long process to transfer the case to Carson City from Washoe County to DCFS. And all the while it's taking up time and the parents could just be getting services. By adding the word domicile, we have got a lot of case law that says a newborn child is domiciled where their parents reside. Takes care of that problem. So it was a simple little word that we talked about a lot in our committee, but one that's really powerful and will help that situation a lot. Section 6 clarifies and expands a provision about persons with a special interest. In child welfare cases, we have a lot of parties, more parties than in typical family law case. Family law case, you often have mom, dad, maybe grandparents and mom. In child welfare cases, we have often a mom and mom's attorney, dad and dad's attorney, the children and their attorney, the CASA, the social worker and their attorney. And then we have a handful of other people who are involved, like the foster parents or certain. The federal government and our state adopted this provision with regard to persons with a special interest, indicating that the court really needs to hear from some people because they have knowledge about the child and the child's needs and the child's need for permanency. So this provision in the statute indicates that if a person is designated as a person with a special interest, they're not a party to the case, but they are entitled to have notice of any hearings, notice of what the permanency plan is for the child, and an opportunity to provide input about that permanency plan, and an opportunity to provide input to the court in court proceedings. So it does trigger some additional protections. With that, we've always struggled since the very beginning of putting that in with how does a person get designated? The statute never said. And so we would constantly have various family members, former foster parents, all kinds of people filing motions in our cases. And we're like, well, they're not a party. And we can't open the floodgates to have even more parties in all of our cases. So we amended that to identify that a court can designate somebody. The foster parent is in court. They generally, they're always notified of it. And somebody can just say, hey, judge, we think they should be designated so that they get all of these extra protections. Or a relative comes to the court proceeding and says, hey, I would like that designation so that I can get these extra protections. Importantly, it also provides for the court to be able to review or modify that designation. We've had situations where a former foster parent was designated as a person with a special interest, and a year has gone by and they're not involved in the case anymore, but we have to continue to notice them because there was never a provision for them being undesignated. So we cleaned that one up. 7, updates and clarifies what is in existing law. Right now, when we have what we call either a protective custody hearing or a 72-hour hearing, if a child is placed into protective custody, the agency has to provide notice to parents. It was an open question as to what efforts do they have to make when we can't find the parent. So that's just one of the things that takes up a lot of time in our proceedings when we're all arguing over what happens if the parent couldn't be found. It also updates the provision and modernizes it somewhat, because the current existing law says that if we're not able to find the parent and either personally serve them or serve them over the phone or orally, that the social worker had to post notice on their door. And we were really concerned about that, because we've had a case, I got sued 4 times because the notice blew off the person's door. And so they said that they didn't get proper notice. And a whole host of us were caught up in that. We also were a little bit...
Ms. Okuna?
Yes.
Sorry to interrupt you. I see that you are kind of going through this section by section. I trust that all of our members have read the bill to prepare for today's hearing. I know that they have done so, and I know that they have some questions. Do you want to open up for some potential questions on the potential amendments? And then if it's necessary, you can give your reasoning as to why the committee wanted to do that.
Absolutely. So yeah, there were just a few more sections, but to the extent that we want to jump right into questions, we're happy to answer any of them.
I think we would like to do that. I know we have some committee members that have another committee coming up at 4 o'clock, so I want to make sure that they are able to ask their questions if they have them. Thank you for that presentation. I will just start off by saying first and foremost that looking at the page of, I believe it's 45 people on that list of people, I know that you guys meet so regularly, and the idea that you have consensus from that many lawyers is a feat in and of itself that's probably worthy of like a proclamation to celebrate as well. So with that, I will go to our first question. I have a question from Assemblywoman Gorlow.
Thank you, Chairwoman. And I apologize. This is not my world of legal. And so I had a quick question about section 1, subsection 1, because it just wasn't making sense to me. It talks about the designee may request that the court issue a warrant to place a child in protective custody. And then it kind of fast forward to if not immediate in the time it would take to obtain a warrant. So I'm a little confused on, you can request a warrant, but is this like an emergency warrant so that it works faster than going through a court warrant? I'm sorry, this just isn't my world, and I didn't understand that.
Of course, Madam Chair, would you like me to go directly to the...
Yes, please go directly to the member.
Thank you. So the way the federal law and case law has come out is that basically you have to have a warrant unless in the time it takes to get a warrant, the child would suffer or potentially suffer harm. And so this provision allows us to get a warrant when we're able to, but it leaves open the possibility of if you are not able to get a warrant in that time. The example I often give is a 3-year-old who's found outside alone. You can't leave that child to go get a warrant. And so that would be an exigent circumstance, but otherwise we would need to get a warrant.
Okay, thank you for that clarification. And then I just had one more quick question. Again, section 1, subsection 4B, it says it's valid for 10 days. Is that calendar or business days?
Under the new rules of civil procedure, it clarifies under there in counting days that if it doesn't specify otherwise, it would be calendar days. And so this one would be calendar days. And the reason for that is because sometimes we know where the family is, but then after we get the warrant, they disappear. So sometimes the agency needs some time to try and find them, although the court can make that a shorter window if they choose.
Okay. Thank you very much.
I think we also have a question from Assemblywoman Benitez Thompson.
I do, Madam Chairwoman, and I appreciate that. And I realize we're racing the clock here in that we're going to start losing members. But I thought what might be helpful is because we know that right now we're building the legislative record that will be reflected upon for this law, and there was so much thought into it. So I was going to suggest that it might be helpful to upload under exhibits the minutes from the meeting, because knowing that we might not be able to kind of do a deep walkthrough on the bill. I thought that the minutes might help, at least in living in our legislative record, or the justification of the bill, or to help flush out understanding and what thinking was. I appreciate Assemblywoman Gorla's question, because I had the same kind of question of, like, for the legislative record, what would be a clear example of reasonable cause in the time frame that you would be looking to define in statute versus an unreasonable example. And so the child on the roadway, you know, Pyramid Highway kind of a thing where you got to scoop them up really quick. Great example. Would you give an example of one in which you would say, okay, workers out there in the field, here would be a clear example of would not meet the standard for the warrant?
Sure, Assemblywoman Benitez Thompson. The most common case that we see where parents are they're found to be under the influence of substances, and a child is present, but the child is not at immediate risk at that moment for the worker to be able to step out. Most of our warrants we can obtain by phone. And so for the worker to be able to step out and out of the immediate scene and apply for the warrant over the phone and get the warrant, that's probably the most common thing that we see.
Thank you. And, you know, I'm not sure if the Community Improvement Program Subcommittee maintains minutes, but if you do, I would ask you to provide those to committee staff so we can make them a part of this legislative record. Because I know that you had several meetings with your subcommittee members and other participants in developing these recommendations in this proposed piece of legislation.
I did have another question on another section, Chair.
That's fine. Go ahead, Assemblywoman Benitez Thompson.
And so I'm just wondering, because I don't know, I see that with the warrant, there's a 10-day process, and that when you go the actual protective order, that's a 72-hour process. So I'm guessing it sounds like this has evolved through case law or through practice, but I was wondering if you could tell us a little bit about 10 days seems like generous, I guess I would say. It seems long, but I don't know if that is indeed true, or why 10 days makes more sense and not 9 versus 11.
So we had a lot of discussions about the timing of how long a warrant could be valid. The 10 days is for how long you can have to execute the warrant, not how long you have after you've placed the children into protective custody. It also is expected that that's the outside limit. That's why we have that provision in there, so that there's a time when we know this warrant is no longer valid. It's our expectation, and I do know that in the Second Judicial District Court, it's anticipated that the court will, in granting the warrant, have a shorter time period. Right now, more often than not, our court is limiting the validity of that warrant to 72 hours. But if we have a good reason, we can get an extension up to 10 days. Based on that example, like we said, sometimes the family flees and you're trying to find them, and that gives you some time to do that.
Perfect. So we should mean this to be up to 10, not a static 10.
Correct.
Great.
May I add some additional information?
Go ahead, and please state your name for the record, and also where you're with, so our members know that you're here to answer some questions.
Jan Hanrahan, Chief Deputy District Attorney in the Clark County District Attorney's Office. I'm with the Juvenile Division doing child welfare cases. And I was leading the committee that put together the warrant statute. I just wanted to add that the 10 days also takes into account what we have down here a lot, and I'm sure Washoe does as well. The kind of situation that led to the case that requires us to get warrants, which is a baby born in a hospital, drug exposed, or to a mom who's not appropriate to take that child home. Sometimes those babies are in the hospital for a period of time, and they're in the hospital being taken care of, somebody supervising mom being in there. And so it kind of contemplates that period of time that the baby's in the hospital too. We may not need to make the official removal right away. So the 10 days was really kind of a compromise. It's true down here as well, where we have a lot more volume, that the vast majority of warrants are served within probably 24 to 48 hours of being issued. So I don't think it's a situation that's going to be taken advantage of.
Do you have any follow-ups with regards to that? I know that a lot of our committee members are kind of at a disadvantage as this touches into a lot of things that we handle in the judiciary committees, but does anyone have any further questions? Seeing none, I will go to the lines to start hearing testimony in support, opposition, and neutral of this bill. Broadcast services, can we go to the lines in start testimony in support of Assembly Bill 426? I remind callers to please clearly state your name for the record, as well as limit your testimony to 2 minutes.
To testify in support of Assembly Bill 426, please press *9 now to take your place in the queue. With the caller with the last 3 digits, 377, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon. My name is Deshaun Jackson, DASHUN JACKSON. I serve as the Director of Children's Safety and Welfare Policy with the Children's Advocacy Alliance. We stand in support of Assembly Bill 426. We believe that this bill is crucial to the safety and the welfare of children, and we also believe that this bill would save lives and would also help with many of the issues that these youth face. Thank you all so much for considering this bill.
Thank you. We can go to our next caller in support of Assembly Bill 426.
With the caller with the last 3 digits, 318, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Nguyen and members of the committee. This is Kendra Birchie, KendraBertschy, and I'm with the Washoe County Public Defender's Office. First, I want to thank the committee for hearing this bill. As you heard, our state is in great need for reforming our dependency statutes. We appreciate the time that everyone put together with this committee. We were involved in the process of negotiating, and the bill that you see before you is the product of a carefully negotiated and crafted legislation that took a significant amount of time from, as you heard, a lot of stakeholders. So although it's not perfect and we have not completely reformed the entire 432B statutes, we believe that this is a very good start and would appreciate your support of this bill. Thank you for your time and attention.
If you have recently joined the call and would like to testify in support of Assembly Bill 426, please press *9 now to take your place in the queue. With the caller with the last 3 digits, 663, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair, members of the committee. My name is John McCormick, JOHN. Last name MCCORMICK. I'm the Assistant Court Administrator at the Nevada Supreme Court AOC. And while our court improvement program has been mentioned several times, I just wanted to call in and register our support for this bill and put our appreciation of all the work that the committee members did, particularly our co-chairs. Thank you.
Chair, there are no more callers in support at this time.
Do we have any callers in opposition to Assembly Bill 426? If we do, can we begin that testimony now?
To testify in opposition to Assembly Bill 426, please press *9 now to take your place in the queue. Chair, there are no callers in opposition at this time.
Do we have any callers in neutral on the bill?
To testify in neutral to Assembly Bill 426, please press *9 now to take your place in the queue. With the caller with the last three digits, 384, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good evening. For the record, my name is Alexis Tucey, Alexis, last name Tucey. I'm Deputy Administrator with the Division of Child and Family Services, and I would like to testify in neutral support for AB 426. I would like to extend gratitude to the Court Improvement Projects for not only working on this bill, as well as continued efforts in improving the system as a whole for our youth and children in Nevada. Thank you so much.
Chair, there are no more callers in neutral at this time.
Thank you. And with that, I will turn this back over to the presenters to see if they have any closing statements or remarks to make at this time.
This is Gabrielle Carr, if I may, very briefly. Thank you. Thank you all so much for your time. I will just say that because of the extensive nature of these committee meetings and that there were 3 subcommittees within it, meeting that we don't have minutes from the meetings we've had. However, I would be happy to provide a summary of what the need of it was, why we did what we did, that might give you some additional insight for each of the sections and give you clarity that might be a little easier and faster to read than minutes would have been for approximately 20 plus committee meetings.
Thank you, Ms. Carr. If we can get those minutes, I think it would be very good to supplement the record, though, regarding the changes to the 432B sections that you're proposing. And again, the amount of work and the time that you all have put into this to gather the kind of consensus that you have among public defenders and district attorneys and courts and court admin is really commendable. So with that, I will go ahead and close the hearing on Assembly Bill 426. And at this time, I will open public comment. As a reminder, if you're providing public comment, please clearly state and spell your name for the record and limit your comments to 2 minutes. Broadcast services, do we have anyone on the line for public comment?
To participate in public comment, please press *9 now to take your place in the queue. Chair, the public line is open and working, but we have no callers at this time.
Thank you. And with that, I will go ahead and end our meeting. Do we have any comments from members before I end the meeting? I know a lot of people are jumping off to go to other committees at this time. Seeing none, I will go ahead and close this here, adjourn the hearing for Assembly Health and Human Services today, and we will see you all on Friday.